Dr. Kean-Seng, very nice to have you on a Friday afternoon. I really appreciate your time. I'm hoping it's the weather looks absolutely gorgeous outside from your end.
Thank you very much, Jeff. And yeah, it's a hot day out here in Western Sydney, but Western Sydney is like that. It's a hot place, 10 degrees above the eastern seaboard a lot of the time, and heat waves, etc.
You've been a GP at Mount Druitt Medical Center for over 26 years.
Yes.
What is it about this community that keeps you so engaged?
So I suppose that's the thing about general practice. General practice is a community based profession. You are part of the community. So Mount Druitt is still in many ways like a small town. And so it's now been, actually, I was adding up the other day, it's actually now been 30 years I've been out here. And so I have almost grown up here. As in, after doing my fellowship and my qualifications, I just came out here. And part of it then is it's the community which keeps us here, which keeps us doctors here. And the community means that it's not just the community within the practice, because that's important, but it's actually the broader community. So this means schools, that means engagement with local government, it means engagement with health. So anything to do with health in the area. So it's broadening the role beyond just what you have in the general practice.
Yeah. Well, what inspired you to, I guess, take a career in medicine to begin with? How did your journey, I guess,
Yes.
begin?
So I suppose you see, like so many of us, it probably starts with lack of imagination. And that is that I was good at passing exams at school. That was fun. That was one. Secondly, I do actually come from a long line of doctors through the family, as in my father is a doctor, my mother's father was a doctor as well. So there've been doctors all the way through. Most of my cousins are in medicine one way or another. So it was sort of a bit of an easy thing to think about. So that's really what started off. I mean, at another level, the other things are that it's practical. It actually does serve that need to be able to help or do good. And as teenagers, as kids, most teenagers are actually quite idealistic. So it's about where can I do good? And this was something which where all of those bits fit together. You can do good. You can actually make a living in this. It's something which the world needs. It's that Ikigai concept, something the world needs, something that you can be good at, something you can be passionate about, and something that the world will pay you money for. So it works.
Have you seen it change over time in terms of the way
Mm.
these students go through the program of fellowship and become
Yeah.
doctors?
So I think that we have all seen changes, and the changes in the last generation, our two generations of doctors, have actually been quite stark. So I would say that I was probably one of the last of a previous generation of doctors. So we grew up in a time where, as a doctor, as a doctor, you did everything you could possibly do. And when I talk about everything, it means everything you can possibly do for a patient, but also everything you can possibly do within the scope. So we call it working to the full scope of practice. So, this means that when I was working in hospitals as an intern, as a junior, as a registrar, as a resident and things, we would be doing things that you would not do in hospitals today. And that meant that we had a great breadth of experience in everything from fractures through to minor procedures and surgery, right through to management of multiple and complex conditions. And so that was good because it gives you a certain level of confidence. And of course, that carries through. But it's also the mindset that you do everything. Now, what we also have to remember is back in those days, this is now going way back. So there's no mobile phones, there's no internet. There's if you want to call a friend, you call a friend either on a landline or you have to go walking. CT scans are not easily available. So something as simple as that. So therefore, we had X-rays, we had limited access to ultrasounds, limited access to CTs. MRIs were things which we'd heard about, and there were probably about 2 or 3 of them in Sydney. So this is a very different world. Blood tests, very limited scope as well. All of those things we have were very limited. So as a result, a lot more was based on clinical acumen. And if you like, that was actually the way that all doctors were trained. Whereas I think what we see now is very much a shift towards lots of investigations, lots of tests being done. And sometimes that's good and sometimes that's bad. And so that's been one of the big shifts. I think the other big shift is in terms of what we can do. And what we can do is a combination of having available medications and other interventions, things like various interventions done by many of the specialists now were things we didn't even dream about back then. At another level, the evidence base, so the quality of the evidence we have now is so much better. And so therefore, we can actually work with things with a lot more granularity, a lot more certainty. And what that also means now is there is a lot more to know now than there was to know then. And that's driven by the fact there's a lot more to do now than could be done then. And that brings you to the next thing. The thing which makes it more complex is that there are now more of these conditions that all come together. So it's no longer a let's treat one condition, it's let's treat this condition in a person who's got 3 other conditions or who has this other problem as well. So there's been a gradual shift. And if we then talk about this from the general practice perspective very specifically, general practice has moved very much from what we call a reactive type care, which means, you break a leg, sprain something, cut something, you get it fixed. You get an infection, you get a tablet. To now where most of our work is preventative care. And that means, so it takes a different mindset and a different way of working.
Definitely, absolutely. Instead of being reactive, we're being proactive in the quality of care delivered
And
to
that is what we
patients.
should be. That's right. Yes.
You are also a MAA New South Wales President.
Yes.
What are some of the key challenges you've tackled during your tenure, and how did that shape your approach to healthcare
Yes.
leadership?
Look, so I was president of New South Wales AMA. So AMAs, of course, have different states, and so I was New South Wales AMA president between 2018 and 2020. So if we think about those years, that means it was 2 years before COVID and the beginning of COVID. It was also years where what we were seeing was a lot of, if you like, a lot of starting to think about what the future of healthcare could look like. A lot of that work in terms of future of healthcare really started in around about 2012. I mean, there was work all the way through, but certainly from a general practice perspective, probably 2012 is the year when I would say in Australia, we really started to pay a lot more attention to that. So so in all of those years leading up to my AMA presidency and things, a lot of the time, which I was trying to do was trying to shift the focus away from, again, reactive. And in this case, it's not so much necessarily reactive care, but reactive approach to the healthcare system. And I actually started thinking about what would the healthcare system that we need in the future look like. And so a lot of the time, it was very much about that. Can we shift the profession? Can we shift that mindset? Can we start to think beyond what it is that we do in our rooms on a day-to-day basis to how does everything fit together and how can we do it efficiently? So some of the key themes, value-based healthcare. So value-based healthcare is, if you like, how much bang you get for your buck. The problem with that is that a lot of the time people just think about the buck. They don't think about what return you get on it. Whereas really the important part is what is your return on investment? So your return on investment can be measured in different ways, but if we don't measure them right, we'll get the wrong answer. So, but ultimately, the return on investment has got to be health. So it's how much better health do you get for the dollar that you spend, whether you spend it out of your own pocket or whether it's spent out of taxpayer funding. And taking on from that as a whole of system approach, and this is where one of my big things is that I think that associations, professional associations, need to think of a whole of system approach, which is how can we then fit that into an efficient health system? Because there are many inefficiencies in health system. And you can actually sometimes, in fact, you can often make things worse by doing things for the best of intentions, but then it has unintended consequences which actually make things worse. And that's very easy to do in healthcare. So this is a lot of where the focus was. I mean, towards that time, so 2019, 2020, that's when COVID starts coming in. And so that was when we were talking about how do we then try to design a system-wide approach to managing COVID. And there actually were plans at that time, national plans, which got forgotten. So they were there, they were developed at the end of 2019, and then in 2020, when things hit the fan, we had a big collective panic in the whole health and political system. And all of those plans were forgotten. And instead, we moved into reactive mode instead. Whereas when I look back at those plans from before, a lot of them would actually have been very, very beneficial if we had followed through. And that's probably a lesson that we all should learn. Sometimes you develop a strategy. Sometimes it's tempting to walk away from the strategy, but maybe the best thing to do is to knuckle down and analyze why that strategy may or may not be working. Do we need to tweak it? But follow the plan. So that's a very big part of what I was talking about, which is how do we improve healthcare overall? How do we make sure that we get the best value in our healthcare system? And as doctors, because AMA is the Association for Doctors, so as doctors, how do we play our role in that as part of that whole thing? And it doesn't mean things like splitting things up. In fact, it's about how best to make sure that everyone works together on achieving the best outcomes. So that's, if you like, the sort of way I'd look at it. And COVID actually became one of those testing points where we could test. And some things were done very well in COVID, and some things were done very badly. And that's part of our learnings. And you always learn from things both ways, whether they're good or bad. You learn. What's important is that we learn. So that, I suppose, is my take-home message about where things were at in AMA between 2018 and 2020.
Your practices were one of three practices that contributed to the COVID Kids program. I guess, with that view, how did this initiative come about, and what was the primary goal of this initiative?
So that is a classic example of where, when we put the bits of the puzzle and the system together properly, then you can actually get a very efficient system. And by efficient, we can measure efficiency in terms of dollars spent, we can measure in terms of outcomes, we can measure it in terms of resources. Because ultimately, health is a zero-sum game. That is, you got the same amount of money, you got the same people, and what outcomes you get just comes down to how you use those pieces. It's like Monopoly. So if we don't use the pieces properly, so as an example, if we shift, and this is a very real world example, and I do apologize, Jeff, I will come back to your question in just a moment, but I will use this to use as a background. So if, for example, you shift a specialist from one area, which is their area of specialty, and I won't say what area it might be, but from one area, and then you move into COVID. What you've done is you've left a gap in that other area. And so I had, for example, patients during that whole time who had end-stage liver disease or end-stage other conditions who were not able to get the usual care they needed because specialists from those fields had been shifted into the COVID response. So that's a zero-sum game thing. It means that, and I'm actually going to say it, I think it means that there would have been many patients who would have had either become sicker or potentially even died because of not being able to get resources that they would have needed because those resources were shifted into COVID. Now, so coming back then to what we did and other practices was that this is about decentralizing the COVID response. So the COVID response at the time was very much an intensive monitoring response. And the intensive monitoring was, to be quite frank, last generation. It was mostly people ringing people up by phone, contacting them, filling in notes on whatever software they're using to go and share this information, and then handing it over. And it was a very labor intensive, very low productivity approach. And it was all centralized well, I won't say all, but mostly centralized through local hospital districts. So the COVID kids one was interesting because it was decentralizing it. So it meant that through a partnership between our primary health network,
For
sorry.
those that don't know what the COVID Kids program is, if you can just kind of give a
Sorry,
brief,
yes. So the COVID Kids program was so in that time where the way of managing COVID was isolation and monitoring. And if there was anyone who was who was falling, getting sicker, it was about early identification in order to escalate and provide better treatment. But really, it hinged on identification and monitoring. So the monitoring was for adults was done by the hospitals and things. For this particular program, which was called colloquially the COVID Kids program, children were assigned to the Children's Hospital Network. And so the Children's Hospital Network was mostly doing all of this monitoring themselves with their own teams of nurses and doctors and things. And as we've talked about that zero-sum game, what it meant was that resources getting shifted into the COVID response and were not available for other things. So through a partnership, the COVID Kids thing was a partnership between the Children's Hospital Network and the Primary Health Network, which is a network in the area which coordinates primary health care. And it was about shifting children who did not have a usual general practice or had a practice which was not able to do the monitoring into this cluster of 3 practices who would do the monitoring on behalf of the Children's Hospital Network. So what it meant was that, and there were a few reasons why we were thinking this would work better. So one of them was that we actually did have resources in terms of capability, but also when we talk capability, capability is 2 things. People, as in staff or humans, but the second one is actually technology. So the technology of remote monitoring is something that we have been doing in our practice since, well, 2018. So we'd actually started this some time back, working mostly with heart failure, with chronic lung disease, with asthma, and in fact, trying to use different ways of using patient apps, so phone apps, and also messaging out. So this means outreach instead of phone calls, messaging, emails, etc., to contact persons who are at risk in the community in order to identify when things were going off the rails. And so, so the system that we had developed was very easily translatable for the COVID Kids program because it meant that we could offer, and it was offer because not everyone has to use the same method, but offer these families access to a app or well, let's just say a web-based platform. And this web-based platform allows them to send messages back and forth to our team, for us to send questionnaires, but also for us to be able to visualize as a team the responses to those questionnaires and track whether things are going better or worse, and therefore how we're going to intervene and whether someone needs to intervene. And the other big take-home messages of that program was that the hospital network was able to be a high escalation level. So that meant that we could put layers below that, where we could have our nurses, our medical students even, as well as our doctors, all being part of that monitoring team. And because we're using a technology-based approach, we were able to scale that and do very large numbers with minimal impact to our usual care, which meant that it didn't divert resources away from usual care. So again, come back to this concept of zero-sum game. Doesn't divert resources away from usual care. We can provide extra care, and we're able to provide it efficiently and effectively. And when we did surveys on all the kids and families that we had contact with and compared the method that we used to, say, more traditional phone-based methods, it was overwhelming that everyone much preferred to use this technology-based approach, partly because they could still use phone as a backup, but also partly because there's better access. They could just send a note to us. They could also see all of their measurements and see whether things were on track or not on track. And we could also escalate to the Children's Hospital as necessary. So it was a really nice little system which worked.
Definitely the aspect of optimizing what you currently have instead of just chucking additional resources and hoping that it works. It definitely it is a much smarter approach.
Yeah,
One
that
thing
was
that was
our
actually
thing.
quite interesting, and in terms of touching on the GP and hospital partnership in itself, um, what role do you think the GP and hospital partnership should play in a post-pandemic healthcare model from your
Mm.
perspective?
So it's interesting because all of those, so that model that I've talked about there was actually developed for a pre-pandemic world. Um, and I always have to be quite sure that I don't take all credit because really this is not an entirely new model. What it was applying a technological layer to existing things which had been done. So we know, for example, in Barwon region in Victoria, they'd already done similar sorts of things with phone outreach to patients with heart failure and found there were improved outcomes. We've seen in other parts of the world, they've done it with asthma, with diabetes, again with good outcomes. So what we did was we were applying a technological layer and setting certain targets and things and saying, if you are at X, then this is good. If you're at X minus 2, then this is bad. If you're X plus 2, this is good. So we can look at trajectories. But so what that meant is that we had already worked out how we would use it for heart failure, for chronic lung disease, for asthma. And, the funny thing, or maybe not funny thing, because this actually makes sense, is that the same methodology, so the same mechanism, the same pathway worked for all chronic conditions. And it also works for diabetes. It also works for, and of course, it worked for COVID. So we were entirely confident it would work for COVID, which it did. So that meant that our next step, if we come now to how we apply our learnings to the post-COVID world, is actually do the same thing and now scale it. So that's again probably one of our lessons here, which is that we spend as a health system too long doing trials and doing pilots. We don't actually scale them up. So what we've got here is something which has been proven to work at multiple levels in multiple places across the country. And so what the only difference now is we've applied a technology layer, and the technology layer doesn't apply to everyone, but what it does do is technology allows us to scale. It allows us to do more with fewer resources. So the logical thing then is to scale that now to more practices and scale it across. We can stick to individual conditions. So for example, we could stick to heart failure. We could say to a heart failure clinic at the hospital, step down. When someone reaches this level here, instead of keeping them at the clinic, send them to us. We'll do the next step. We'll do the monitoring. If they need to go back, we can go back there. So that's a sort of relationship, which is that usual care, monitoring, preventive care, chronic disease management. That is what general practice is here for. This is what we do. Not only that, we can also look at it in terms of, say, not just that one condition, but actually all of the conditions. So someone who has heart failure, kidney disease, and diabetes is actually a different picture to someone who just has heart failure or someone who just has diabetes. It's a different picture. It needs a different list of medications, which is something which we do and which I do and which we have good evidence as to how that works in general practice. But it's not so easy to do that if you're in a hospital clinic, because in the hospital clinic, all you're doing is you're seeing that one condition. So inefficiency. If you're doing it so the hospital clinic doesn't do that. What they do instead is they refer to multiple clinics. So from a hospital perspective, that's inefficient. I mean, the hospital is basically using up more resources. From a patient perspective, and we think about this one, if I'm a patient, do I really want to be spending my week going to 3 different clinics? I mean, again, not efficient either. Poor productivity, poor use of my time, poor use of my family's time, poor use of everything. So again, this is why that concept of if we were to scale it, what would that look like? And the answer is it could actually look like, why not, as a patient or as a family, do your own monitoring, have support from a usual GP. If things going off the rails, you still have the clinic support there. But rather than having the necessary, let's go to this clinic or that clinic or that clinic, the first point of call is there something to be done or not? It's almost an algorithm of on target, good, keep there. Not on target, now we do something. So, or trending off target, which is actually another key thing, because we know from the remote monitoring experience, you can actually see where things are starting to trend off target. And we start to see that early intervention before things really go off the rails. So it's about saying, so coming back to your question, that relationship is got to be that one of appropriate and efficient service, what's the term used? Delivery, service delivery, trying to find the right words. Anyway, about trying to split things up the best way to make sure that everyone's doing the jobs they're best at doing. More importantly, not doing things that you're not efficient at doing, because, well, I don't see why we should. And this is a thing here, even though doctors and associations will often say we need to spend more money. I actually don't think we need to spend money if it's not being spent efficiently. We do spend more money if it's going to build efficiency. But if it's not efficient, we should not be propping up an inefficient system.
You mentioned earlier on your return on your investment. What are the biggest revenue challenges GP practices are facing today?
Yes. So we can look at that in two ways. One of them is the total quantum, so the total amount of revenue which a practice gets. And of course, the second one is how does the practice get that revenue? Because how you get the revenue actually dictates to a large extent what you do. And that's a practicality for most general practices. I mean, in our practice, you've probably worked out we're happy to do a lot of experimentation. We're happy to do a lot of things, which, to be perfectly frank, are things which I cannot expect every practice in the country to be doing, because a lot of that stuff is not remunerated. And this is where we now come down to the challenge. A lot of stuff I've been talking about, remote monitoring, asynchronous messaging, which is emails, text messages, whatever. No Medicare rebate. So therefore, no Medicare rebate means you pay for it out of your own pocket or out of your own time, or you don't do it. It's really that simple. So the quantum of funding has been a big issue. That is that if we look at the total amount spent on general practice as a percentage of health spending over the years. So everyone talks about raw numbers and they say 7 billion. It's about 7 billion being spent on general practice a year, roughly. But that represents, if we look at it now, about prior to this government coming in, it represented about 5.5% total spending. Whereas if we went back about 5 years before that, the total amount being spent compared to total funding was over 7%. So therefore, the amount being spent on general practice over time has gone down. And that has restricted what general practice could do. And given that we all know cost of living has gone up, cost of living is electricity, rent, staff wages, because when we talk about general practice funding, the rebate doesn't just go to the general practitioner, it has to fund everything. So the premises, the equipment, the dressings, everything, all of which prices have gone up. So what that's meant is that for many practices, the challenge is the choice. The choice is that you either have to reduce the number of staff, which means you can't do as much, or you reduce the level of service, which means you do faster appointments. So people who complain they can't see their doctor as long, you're probably right. It probably is that. And part of it is that there's been this push to have these services running through faster. Or you have to reduce the quality of things, such as those poorer quality dressings, have less people on the front desk to man phones, this sort of thing. Or you have to privately bill, and that's the other thing. So that's where the drive to privately billing is. So funding is a big factor. But I'll then come to the second part of the equation, because I mentioned there's two. There's a quantum, which is that the quantum has gone down, and it has not kept up with inflation. But the second one is actually how, because if you were to take this from a purely business perspective, you would only do what you can get paid for. And that is problematic, because what you get paid for may not necessarily be the best thing for a person's health. So if we put health as a priority, then it means that sometimes some things which are going to work best for someone are not covered by Medicare rebates. And that's actually one of the big problems we have with Medicare at the moment, which is that it puts all of the money, really more than, well, not quite all, but probably 95% of the money up at the fee for service level, which means you get money for doing a thing. And if you don't do that thing in real time, you get no money. So remote monitoring, no money. Messaging, no money. If someone rings me up and asks for a prescription, then I just write one up. It's very convenient, saves everyone time, efficient for the system, no funding for that. If someone, say, wants to ask some advice about something, again, if I take the phone up and just ask and give them, I might get some money. But if I give an email and say, let me send you back a response, and that's the way the world works now. We don't do things in real time. We do things asynchronously. No money. Again, similarly, remote monitoring. What if I said, just send me through your measurements for your blood pressure every month? Let me have a look at that. Send me through your mood scores every month. Let me have a look at that. And then I'll just make sure I touch base maybe twice a year. We can make sure things are on track. None of that's funded. And if we then take that a step further, my team who we have here, who I really cannot work without, our dietitian, exercise physiologists, who've been with us for the last 10 years and do all of this stuff as well, not getting any funding for that either. So these are all the things which we can, which could be done more efficiently, but are not because of the way that the Medicare rebate is paid, which is that again it becomes a roadblock to improving healthcare overall. So those are sorts of challenges, which is at a practice, it's money, but also even if a practice wants to do something different, they've got to make a choice, which is do they forego income? And that's a bit of a decision that we've made here, which is saying we will forego some income, but it also means that we charge, we are a mixed billing practice, which means we actually do charge the private fee as well for some patients, because this is part of the swings and roundabouts and part of that whole trying to make being able to provide the services that we know, and I'm going to say more than think, which we know actually provide a better healthcare experience. We also know we can do better, but these are the choices we make.
That's awesome. I want to touch on the building the future of general practice. Obviously, there's been a plan that has has been announced around the investment that they're looking at general practice. You've integrated GP services with local schools to enhance the public health. How did this initiative come to life, and what advice would you give to other GPs that are potentially looking at something in terms of integrating partnerships with whether it's local schools or hospital systems?
Yeah, look, I think that your word about the partnerships is really the best way to put it. It's not, and that's a key word rather than the integration, because the partnership is what happens. And I would say to anyone who is looking at it, GPs, other health workers in the community, whether they be pharmacists or nurses in the hospital or allied health workers, is that the partnerships are what makes healthcare, well, I'm going to use the word easy. It's not doesn't make it completely easy, but it makes it easier. The partnerships are key to making things easier and improving professional satisfaction for two reasons. One of them, you're not doing it alone. If you're a partner, you're not doing it alone. So you go further. Second one, though, and of course, when you're doing it alone, it's a pretty lonely place. But the second one is it actually becomes more efficient because you're sharing the loads, and that means everyone can actually do things that they're good at. So anyway, so let's talk about the schools one, for example. That's SALSA, which is the Students as Lifestyle Activists, which again, I can take very little credit for because the big driver behind that one is Professor Smita Shah. And Professor Smita Shah started off with a similar project for asthma. What we were seeing in our local area was that there was a need to work with lifestyle. And even though we talk about weight as a thing, it's really about healthy lifestyle. That's the underpinning of it. And healthy lifestyle is about habits, diet, exercise, knowledge, but also translating all of that into behavior. And so that one, without going into the details of the program, is a partnership program between Samita, who's from the public health unit at Westmead, as well as Rooty Hill High School, which is where we started, but has since scaled and grown across to other high schools in the region, and of course the Mark Druitt Medical Practitioners Association, which is a group of doctors in this area, of which I also happen to be president of, which makes the whole partnership easier. But the reason why it started was there was seen to be a need. There was also seen to be a problem. The problem was that teenagers don't generally go to see their doctor. And there's many reasons why, but generally they don't. And so there was that need. Then thirdly, that knowledge is one thing, but behavior change is another. So you can tell anyone anything, but it doesn't mean it's going to change anything. So, so that then goes back and says, well, what is a good way to stimulate both knowledge as well as behavior change? The answer was peers. And this is not something that I would have thought of as a doctor, but something that the group, which means the teachers, the PDHPE teachers, particularly at Rooty Hill, as well as our contacts and friends there, as well as Professor Shah. These were all things which they could put together to help put together the program. And the way we got those partnerships initially was through our, as an association, actually giving bursaries to students from the local high schools who were going on to study health-related courses. Because again, that was another thing, which is that students really, well, going from high school to universities is tough. There's a lot of expenses, there's a lot of changes. And if you're from some of the schools here in Western Sydney, you may not be in as privileged a sort of area, may not have as privileged a background as some other areas, which means that a little bit of extra help at the beginning can make a difference. So those are sorts of partnerships we're able to forge. And some of those same students came back to work in Western Sydney. So in fact, some of our best advocates and partners at Rooty Hill High School were recipients of this bursary before. So there's this really nice circular community approach, which comes back to one of our first points there, which is it's all part of the community. And so without going into the details of the program itself, it meant that it could be co-designed with those teachers and students, the community. It then becomes a living thing within that school, which then means that it can be scaled across, because it then means that as the group who are organizing in the first place, we don't have to be involved as intensely at every single step, which means that we can again scale it out further. So again, scale and efficiency.
All about efficiency, isn't it?
Yeah, that's it.
What policy changes would you like to see to be better support GPs as the cornerstone of Australia's healthcare system?
So, so the first step of that one is we have to go right back to say, what is it that general practice does? So what is the role of general practice? Because I think one of the problems is that we tend to think of general practice either as a sort of low-level emergency department or a place you go as a reactive sort of care situation where you need something to be done. So as a low-level emergency department, that means dealing with all this stuff. And, it's a fallacy which we often find that those who work in hospitals have, which is that they actually think of general practice as a low-level emergency department. Now, when we actually analyze what general practice does, general practice, and we look at, say, numbers of conditions. So overall, 50% of people in Australia have one or more chronic conditions. About 25% have two or more, about 12.5% have three or more, and so forth. So it's actually a remarkably consistent mathematical progression. That mathematical progression actually does change a bit more, so that if you're in a more disadvantaged area, the numbers are higher. So if we compare Mount Druitt to, say, Mossman, the numbers are actually quite different there. But overall, it sort of splits at about that sort of progression. So if we look at that, we then say what amount of time in an average general practice day is spent on doing what. And so on average, and it depends on the practice, so in a practice like ours, which has been here for, well, almost 50 years now, and I've been here 30 years, when most of my patients have been with me for a long time, we have actually 5 generations now of patients coming through. It means that there is, and there does tend to be, quite a lot more chronic conditions. So when we do our analysis here, 85% of time is spent in managing chronic conditions, as well as preventative health. And by preventative health, that's everything from cervical screening tests right through to looking at heart risk assessments, intervention for overweight, interventions for smoking, and so forth. So when we look at that, that's 85% of the time and 85% of the workload. So that's the first step. We've got to say, what does general practice do? And the answer is this much in the way of acute care, this much in the way of preventive health and chronic disease. So the funding, therefore, has to look slightly different. So if we look at the Medicare system, fee for service, which means you get a fee for providing a service. What that means is that, and that works because if you have a fall, if you come and see me and you've got a broken ankle, I can help you with that. That's a service. And Medicare works fine for that because you cannot predict that fall. You cannot predict that you were going to, burn your arm on an oven or something like that. You cannot predict these things. These things happen, and that works fine. You get COVID and you get unwell because of that. Okay, we can't predict the COVID, so therefore that is fine. That is all fee for service. But let's look at all the other things. To prevent that COVID is vaccinations. If you've got other health conditions which make you more prone to getting, say, heart problems, lung problems, and things such as pre-existing heart disease, pre-existing lung disease, then to prevent you from going to hospital from COVID, we would want to be making sure that those other conditions are best managed. That's the bulk of the workload of what we do. And so that's a combination of counseling, combination of medications, but monitoring as well. And so if we think about that, then what we really have is we should be looking at a funding system which has acute care or reactive care, and then chronic care or management, which is going to be a large part of that is going to be I actually think this part is something which should be a fixed, which should be a pool of funding to the practice, where the practice actually applies that pool of funding in the way that works best to reduce the outcomes. And this is where we now talk about where it gets interesting in terms of what does the future look like. So one thing which most people find amazing and actually don't realize is the amount of knowledge we can get or insights we can get from the data we have. So we can predict with a high degree of accuracy, probably greater than 85% accuracy, the probability that anyone is going to go to hospital in the next 12 months. And we can also split that into the reasons why. So I can say to someone, right, you've got a 30% probability of going to hospital in the next 12 months, and it's more, and the biggest contributors at risk are heart disease, lung disease, and smoking. So therefore, if we were to cut out the smoking, we can reduce the risk by this much. If we were to look at your medications you're on for your heart disease, which I can see here are not at the optimal level, we could probably reduce your risk by another 20% if we do that. So we could reduce your risk from 30% down to, and unfortunately it's not 30 minus 20, it's 30% minus 20% of 30%, which means we could reduce your risk down from 30% to maybe 22% if we do all these things. And that's a sort of conversation which we can actually have now and we can actually proactively plan for. But none of that sort of data analysis, none of that team that we need to do it, because we actually think about it, not all of that needs to be done by the doctor. A lot of that can actually be done by the nurses, by the pharmacists, and even in fact by the allied health. But we're not funded for that at a general practice level. So none of that sort of stuff is funded for a general practice level. So we're not doing preventive care as well as we could because we're not funding it. Now, at another level, in terms of our general practices able to do that at this point, I suppose the answer to that one is that it takes time to learn and to train the team up to do that. And, we've been playing this game now for the last 15 years, gradually building and building on it. So it isn't something that you come to overnight. So therefore, if you look at what would the future look like, it's a combination of looking at that funding model, changing some of that funding model so we can actually fund broader team-based care, and we can start to look at how we measure it. But we also need to fund training and upskilling, because if you just fund things the same way, all you will get is more of the same. And and that's always the problem when you use existing models, because existing Medicare is, it served Australia well. It's been around for 40 years, but the world we live in today is not the same as it was 40 years ago. People are not the same. Technologies are not the same. Medications, interventions are not the same. Knowledge is not the same. So in which case then, how proud should we be of a 40-year-old model if it hasn't actually evolved with the time?
I would love to just finally touch on personal reflection and advice for GPs. You've been doing this for such a long time. What has been the most fulfilling moments as a GP and a healthcare innovator?
I think because our approach here in our practice, I'm going to use the our because one, I don't like to take all the personal credit because it really is everyone in the whole team which drives what we do and drives the practice and keeps us going. Because if you're doing it on your own, it's a hard and lonely job. So you do need your friends, you do need your team to support you, and we all need to support each other. So I'll use the our. So our approach here at the beginning, and this is where we started, is we've said, who wants to come along? Who wants to make it better? We can't guarantee that you will make more money, but what we will do is we'll make sure that we do our best to make sure that everyone is comfortable. But what we will guarantee is that you will have more satisfaction and you will have more fun doing this. And so it's about the let's make sure we can do the best job we can because that's professionally fulfilling. So coming back then to what are some of the great joys? It's actually having that team, and it's actually seeing a team where we can throw a problem. And this is the thing, we can say, right, we've got COVID. What are we going to do? And the team actually comes up and says, no problem, we can deal with it. So it's about having developed, having grown up with, having co-designed with this whole team, that sort of approach which allows us to take problems on and actually create solutions. So one thing we haven't touched on, but I've sort of alluded to, is technology. So technology solutions, such as we've talked about, how one of the things which I also did was co-founder of a product called Care Monitor, which is a cloud-based patient monitoring, but also messaging and also care integration platform, which allows integration with other health practitioners. And that was all designed with the help of the team because this is our experience. We said, this is what we can do. This is what we want to do. How can we do it more efficiently? What tools do we need? And Care Monitor is a result of that. We have other tools we work with, other tools we've designed along the way, and we then design the workflows to make them all work the most efficiently. So it means that everyone in the team actually becomes part of that. And so when we think about fulfillment, that's what gives us fulfillment. It's being able to do that and then actually being able to see the outcomes at the end. And when I say outcomes, so for example, we know that over time, even though we know the smoking rates in the area are one of the highest in the country, we know that if you're a regular patient in our practice, your smoking rates are going to be half of what it would be expected to be, or less than half of what it's expected to be overall. What we also would say is that if you look at our hospitalization rates and hospital attendance rates for patients who come to the practice as regular patients, we can also say that we can produce better outcomes. We can say that things such as, if you come here, we can tell you that 85% of all patients who come to this practice have the outcomes which are within a or better than benchmark, that your medications are more likely to be on within a what we call guidelines management or within the guidelines for management, that we are likely to therefore see, and this is a part where I say likely because I can't prove it all the time, but likely to see a slowing down in your progression of ill health over time. So basically staying as healthy as possible. So these are all the sorts of things, and it takes time to build it, but that's the sort of thing which gives us as a team satisfaction. It's actually being able to do a better job. Our challenge is, of course, that we've got to also be able to make it pay, and everyone still, at the end of the day, has to be able to pay their mortgages, they have to be able to pay their bills as they come about. So that's the other side.
Finally, what advice would you give other GP practice owners or practice owners who
Yeah.
want to stay ahead in a very evolving healthcare environment?
Yeah, I think the first thing which I would say, and I've probably got probably one main statement and then probably two to follow on from that one. The first one is know what is your Ikigai? What is it that you're there for? What is it you're there? Why did you do medicine? What is it you're there for? Was it to make money? Was it to provide good outcomes? And it's not mutually exclusive. It is about being realistic and saying you have to, if you're not making enough money to actually pay your bills, then you're not going to be able to do anything for anyone, so you'll be out of business. So it is a business, but it's also about what is the purpose. And so know your purpose. That's the Ikigai. The second thing I'd say then is, having said that, having known that, ask yourself about, how are you going to provide care best? And is it going to be Medicare dictated care? And that means you only do what Medicare pays you to do, which is okay. You can do that, and that works for many practices. Or do you, or is part of your Ikigai to actually go beyond? And of course, how far beyond you go depends on what's needed at that practice. So everyone has to look at their individual circumstances. That means their team, their time in life. But ultimately, it is about looking at the big picture, which is, what makes you satisfied? Because unfortunately, I see many doctors, and I'm not talking just general practice, I'm talking everywhere, who look back and say, I'm not sure I would have done it if I'd done it again. And I think at the end, our marker of success is you've got to look back and say, okay, whether things went the way you wanted it to go or not, whether you got everything exactly the way you wanted it to go or not, would you go back and do it again? And I think if you can say that you would go back, you would take the journey, you would do it all again, then I think that's a successful life.
Thank you very much for your time, Doctor. I really was honored to share this time with you.
Thank you very much for talking, Jeff, and thank you for this opportunity to share these.